Alright, so we're going to commence the static posture assessment from the posterior view, and we're going to begin at the ankles or at the feet and work our way all the way up to the head. So the first thing we want to do is get behind the client, and we want to look at their Achilles. And what we're looking for here is how vertically aligned both of the Achilles tendons are. And if we look at Ben's here, the first thing we can see is both Achilles bowed medially just slightly. We see that? Yep. So both Achilles bowed inward. And what that means is that he has slightly collapsed arches, or he's a little bit overpronated. So on our postural appraisal form for the feet, we're going to tick pronated, and I would call that slight for Ben. But it is really important when you position yourself to look at this pronation that you stand back probably between 1 and 2 metres, get down at the level of the Achilles so you can really get a good gauge on that degree of pronation. Now what I also like to do while we're here is move myself slightly to the side, and you can check out how fallen or collapsed this longitudinal arch is. Now this is the main arch of the inside aspect of the foot, and if people are slightly bowed or pronated here, then you'll see that that arch is going to be slightly collapsed. Now I'll confirm that from the anterior view, but sometimes it's just worth noting whilst you're here, and that can give you a degree or an indication as to how severe that pronation and or collapsed arch is. So after we've looked at the feet, I move up and I just check out the level of asymmetry of the calf muscles or gastroc-soleus complex. So I'm going to come behind here and I'm just going to see if there's any difference in bulk there. We typically see this with unilateral athletes where they use one side of the body more than the other, but looking at Ben's, I don't think we've got any huge asymmetry there. Then if we move up to the knees, the next aspect that we're going to look at is the smile or the creases behind the knee. Now I'm looking for if they're level here, so they should form, I mentioned smile before, they'll angle down, so it should form a smile if you look at both of those creases together, and we can see Ben's does exactly that. And then I'm just going to come back and have a look to see if one crease is higher than the other. So looking at this, I'm going to suggest that the crease on Ben's right leg is slightly higher than the left. Can you see that, eh? Yeah. So immediately my suspicion is that there may be a slight leg length discrepancy here, and I'm going to confirm or deny that when I get up to the hips. Alright, so at the moment I'm just assuming that that right leg might be a little bit shorter than the left, but we need to go further along in our investigation to ascertain whether that's the case. Then we're going to move up to the pelvis, and the two bony parts that I want to palpate and feel are called the PSIS, and that is the posterior superior iliac spine. Now if we look on most people, you'll see these dimples by the side of the lumbar spine, and that's what we're feeling for. So what I'm going to do is kneel down, and I'm feeling for the two bony bits that stick out the back. So for Ben, and Ben, you can feel me on those bony bits there, can't you? That's the PSIS right there. And using my thumbs, I'm going to have a look at that and see if they're level. Okay. Now looking at that from my perspective, that does look pretty level. So remember I mentioned that we had this suspicion of a leg length discrepancy. If that was carrying on through to the pelvis, I would expect to see this. I would expect to see that right PSIS higher than the left, but he's automatically corrected. So what I'm suspecting now is that this is possibly due to a different degree of collapsed arch down here, so it may not be a leg length discrepancy. And as a PT, I can't diagnose that anyway. I'm just checking the levels essentially. Alright, so I'm just going to look further up the spine now. And I'm going to get Ben's permission just to palpate up his spine, starting at lumbar, moving up to cervical. So Ben, is that alright? And I'm just feeling for the transverse processes, which are the bits that stick out the back. And as I'm palpating, I'm feeling for any sort of abnormality, and I'm looking for any sort of curvature to the side, which is known as scoliosis. So by palpating from the bottom to the top, I've detected and you can probably see this in Ben's thoracic spine, it curves slightly to the right. Alright, so on my static posture appraisal form, I'm going to note that he has a slight scoliosis in his thoracic spine to the right. So I'm going to take that into account when I do my debrief and then my programming for Ben. The next thing I'm going to look at are his shoulder blades or scapula. Now I'm going to feel for the inferior angle bilaterally. Now what I can do here from this position is just see, if one's higher than the other. Okay, and looking at that, I'm going to guess, Ben, that you're right arm dominant. And he's confirmed that he is right arm dominant. And typically what you'll see is this right scapula, which is the dominant arm in this case, will be depressed and a little bit protracted. Okay, so we've already identified that it's a little bit depressed. And then if we look at my thumbs, can you see that right thumb is a little bit further away from the spine than the left? So that means that he's been pulled into protraction. That means his pec minor here is a little bit tight. All right? And this is classically what you'll see with people on the dominant arm in probably 90% of cases. So in my programming, I'm going to note that I need to pull that right shoulder blade back into retraction and get a little bit of elevation so we've got symmetry. All right, so that's the scapula. Now the other thing we note when we look at the medial border is if there is any winging. Now when we're talking about winging, this is where the medial border sticks out like this. And you will see this a bit in unilateral sports, so all your throwing athletes and some of your track and field athletes like javelin, shot put, discus, where they predominantly use one arm. You may tend to see some winging. Your desk jockeys, people that work in IT and admin that drive a desk for long periods of time, you'll also start to see this winging. And that's the result of a weakness in a muscle called Serratus Anterior. Now, serratus originates here on the inferior angle and wraps around. And its main job is to lock the scapula onto the thoracic rib cage. Okay, so it makes sense that if that's weak, that's going to allow that medial border to become more prominent, and that's going to affect how it moves when we're moving the arm. So what I would note there for Ben, I'm not concerned about any winging, although there is a slight raised medial border here on the right. But I would note that this right scapula is a little bit depressed and protracted. Okay. Now moving up, the next thing that we'll note is the Acromion process. So to find the acromion, you need to find the spine of the scapula, which in Ben is here. And I'm going to follow that laterally until I find the bony prominence on the front of his shoulder. And I'm going to look for those two bony prominences and see which one's higher and which one's lower. So standing back here, I think we can safely assume that the right acromion is a little bit lower than the left. And this aligns nicely with what we identified here, with this shoulder blade being depressed a little bit. We can see that the acromion is a little bit depressed as well. And we can see that Ben has a little bit less tone in the upper trap here than he has over here. Okay, so we've got to work a little bit on upper trap and lower trap and serratus here and release that pec minor to get it back into a more neutral shoulder posture. Okay, so that's the posterior view. What I'm going to get Ben to do now is turn side on. Yep, anyway Ben, that's fine. And then we're going to start our assessment from the feet and work our way up to the head. So the lateral view or side on view certainly doesn't take as long as the posterior. And the first thing we're looking at here is whether Ben can hyperextend his knees. So what I'm going to ask him to do, Ben, I want you to actively push your knees back into a lockout position. Great. And what we're looking for there is to assess any hypermobility around the knee joint. So you'll see this with some females where they are hypermobile and they'll get this sort of reverse bulge at the back of the knee, and that is a sign of hypermobility. Now that's important to assess because if somebody does have that degree of laxity there, their posterior cruciate in the back of the knee is on stretch, and we have to be careful taking them to lockout with exercises like leg press and lunges and deadlifts, etc. So Ben is not hyperextended. He's good, so there's no sort of contraindications there. But if I did have a hypermobile female, and I say female because more commonly that's the population that do demonstrate this, then we just have to be careful about our end of knee extension activities. That makes sense. All right, we're going to move straight up to the hip, and we're going to assess the degree of anterior pelvic tilt. So the two landmarks we need here, one is the PSIS or PSIS, and remember we identified that from the posterior view. That's our dimple, which is here. And then the other landmark is the ASIS, or anterior superior iliac spine. So I'm following the ilium across, and I want to find this little bump on the front where if I go any lower, I fall into the hip flexor, or the iliopsoas. So I'm right here, and what I like to do is put both fingers parallel to the ground, and then I can clearly see the degree of anterior pelvic tilt. So from this angle, it's going to be difficult, I'll try and get out of the way so you can see this. We can see that the front hand is lower than the back hand. So if we can imagine that Ben's pelvis is a bucket of water, the water is pouring out the front because he's in that anterior pelvic tilt. Okay? And you'll find this with 80% of the population, they'll be in a degree of anterior pelvic tilt. People that are more pronounced with this are those that drive either a desk or a car for long periods because they're in a hip flexor shortened position for long periods, and that's going to pull them into anterior pelvic tilt. Okay, so we've probably identified that Ben has a moderate anterior pelvic tilt there, and in conjunction with that, if we move to the back, we can see that he has a bit of lumbar lordosis or excessive lumbar curve right there. All right, now these are a pigeon pair. If you have one, you're guaranteed to have the other. So on your little postural appraisal form, when you identify an anterior pelvic tilt, you will also note that there's a lumbar lordosis. Makes it easy. Have one, must have the other. And what that lumbar lordosis means is that we don't have equal distribution of weight through the intervertebral disc. So if you can imagine, this fist is one vertebra, this fist is another, and then you've got your little pad of cartilage, which is the intervertebral disc in between. If we have a lordosis or a flat back, then we don't have equal pressure through that disc. So people that do demonstrate a lordosis or the opposite, which is flat back, are at increased risk for disc prolapse at some point. Generally, this will happen in middle age, when a lot of the fluid has leaked out of that intervertebral disc and evaporated, becomes a bit more brittle, and that's when small movements or a combination of flexion and rotation can lead to low back injury and prolapse of the disc. Alright, so we've identified an anterior tilt and we've identified a lumbar lordosis. Let's move up the chain a little bit. Now when we see a lumbar lordosis here, the next thing we need to check is, does Ben compensate for that by going into a kyphosis further up? Okay, so he's actually not too bad. He's got quite a long thoracic spine through here, but I don't believe that he compensates too much with a big kyphosis. He's probably got a really slight one there, but I'm not too concerned. So with a kyphosis, I'm really talking about this exaggerated hump or curve that you see on some little old ladies. And sometimes that is an adaptation to a big lumbar lordosis because the spine has a way of trying to even itself out. So if there's a big lordosis, it'll try and compensate by developing a kyphosis further up. But Ben's actually not too bad in that area. Alright, the next thing that we're going to look at from here is the alignment of the acromion process of the shoulder. And remember, we located that by finding the spine of the scapula and coming across. So there's Ben's acromion right there. And we're going to line that up with a little bony protrusion here called the mastoid process of the temporal bone. So the temporal lobe or temporal bone sits here on the skull, and it has this little bony protrusion behind the ear. Okay, feel that on yourselves when you get a chance. And we're trying to draw a vertical line between the two. So if we have a bit of a look at Ben's, he's actually not bad. What we can tend to see if people are really round-shouldered, we'll see this kind of protraction and tipping of the scapula. Or the other thing we'll see if people are demonstrating a poke chin if Ben just pushes his chin forward, you'll start to see this once again with people that look at a computer for long periods of time or drive a car. You'll start to see that poke chin posture. And just come back to normal for us, Ben. He's actually quite good with both of those, so I'm pretty comfortable with where Ben is at with respect to his neck and head posture. All right, Ben, we might do the last view, which is anterior. So if you can turn and face us for a moment. And once again, we'll follow our system of moving from the feet up to the head. Now, what I might get you to do in this instance, Ben, I just want you to do 3 very tiny little jumps just so you can relax into your natural posture. Yeah, great. Now, what I did notice when I looked at Ben from the posterior view, he was in slight external rotation, which means his feet were splaying out just slightly. Now, if we look at his right, can you see that that's pointing out a little bit in comparison to the left? So that's coming from the femur, because what we have to remember here is the knee is a hinge joint, so that rotation can't really come from the tibia. You can get a slight amount, but typically speaking it comes from external rotation of the femur. So you're a tight ass. So what we've picked up from that is that Ben has a tight glute max in particular, and piriformis in the right side, that's pulling him into hip external rotation. So he does have a little bit of an asymmetry there, and I would only call this slight, but it's something worth noting, and I'd probably prescribe some glute stretches for him as part of his warm-up and part of his homework to try and pull that back in so it's the same as the other side. All right, now from this anterior view, this is really just about checking what we saw from the back. So remember we identified that whipping inwards of the Achilles tendon and that bit of pronation. So from the anterior view, we want to double check and just have a look at these longitudinal arches. And they're generally okay, so he's only got slight pronation bilaterally. If he was more pronated, this would be more horizontal and flat in here and in here. So generally he's pretty okay. The next thing I'm going to look at is the orientation of his kneecaps or his patella. So what we want to see is that both kneecaps are pretty much pointing straight ahead. And we're looking for symmetry here. So does one point in a different angle to the other? And if we come back and have a bit of a look here, look, there's generally not much to talk about there, to be quite honest. The next thing I'm going to get Ben to do is to stand with both feet together. Now what we're looking at here is the space in between the knees. So this is going to tell us if he is bow-legged or if he's knock-kneed. Now you can see from this position that Ben has a slight bow-legged posture. This is also known as genu varum. And what this means is that, once again, to use the same analogy that we used with the spine, his knee joint doesn't have equal weight distribution. So he's at risk for some meniscal irritation and perhaps tear if he gets in the wrong position. So he's slightly bow-legged. As an example, if you look at mine, I'm the same. I'm a bit bow-legged. All right. So I'll just get you to stand back to a normal posture for me. In terms of the implications of being bow-legged, there's really not that much we can do, but if we do identify somebody that's bow-legged or knock-kneed, for exercises like lunges, step-ups, deadlifts, and squats, we just need to make sure that we reinforce correct alignment of knee over second toe. Because what Ben will want to do, he'll want to kick out a lot, and people with knock knees, guess what, they're going to want to kick in. So we just want to make sure we're keeping an eye on that alignment to make sure we've got as good an equal weight distribution as we can through that knee. All right, moving up to the pelvis. What I'm going to do now is palpate both ASIS. Okay, so I'll get out of the way so hopefully you can see that. And all I want to do there is check to see that they're level. So remember we had a look at both pieces from the back and they were level. So really I'm just confirming that from the front. And I can't see any real issues there in terms of one side being elevated compared to the other. So that's good. The next thing I'm going to do, moving up a little, I want to take a look here at the degree of internal or medial rotation at the humerus. There's two easy ways to pick up on this. One is the gap between the torso and the elbow. And just seeing if that is symmetrical on both sides. And if we look at that, it's pretty good, isn't it? There's not really a difference there. Sometimes what we tend to see on the dominant arm, we can see this happening. And as you can see, when I take Ben into that medial rotation posture, that's increased the gap in here. So those weightlifters or bodybuilders or weekend warriors that train a lot of lat and train a lot of pec, which are both powerful medial rotators, they're gonna stand like this, okay? And that's a recipe for shoulder impingement up here. All right, but if we get Ben to go back to a normal posture, he's generally pretty good. Now, I mentioned there are two things we're looking at here. The other is the orientation of the knuckles. So if somebody is medially rotated, the knuckles will face you. All right, so you'll look at this and you'll also see the knuckles facing straight ahead, whereas if we look at Ben naturally, they're pointing out this way. So he's pretty good in terms of his degree of medial rotation. Okay, so now moving up, the next thing we want to do once again is confirm what we saw from behind in terms of the height of the acromion processes. So I'm going to get those two bony processes in mind and I'm going to come back here and just confirm. So remember from the posterior view we identified that the right one was a little bit depressed in comparison to the left, and Ben told us that that was indeed his dominant arm. And looking at it from here, gee, there's not much in it, is there? You can see both clavicles or collarbones are pretty close to parallel to the ground. We can see similar tone in the upper trap here, so I'm less concerned now about that right shoulder than what I was looking at it from behind. Okay. Now the final thing I'm going to look at here is his head and neck position. So my points of reference here are the midpoint of the chin and the manubrium of the sternum here, which is that little divot in the top. Okay. So when they used to teach you CPR, if they teach you the caliper method, they teach you this sort of deal. Put your finger on the xiphoid process and then the other one in that little notch or manubrium there. So we want to make sure that we've got good vertical alignment there, and if we get Ben to just stand as naturally as we can see that he does have good vertical alignment there. So that's pretty much it in terms of the three views. So just to summarise, it's important that we do a good pre-frame right at the start to ensure that the client is aware of what you're about to do and why you're doing it, and to get informed consent. Make sure you use a well-lit private area to do the consultation. You're looking at the posterior view first, starting at the feet and going to the head. Then ask the client to move into a lateral view, and once again feet to head. And then finally the anterior view, feet to head. And then the third part of the static posture appraisal is sitting down with the client and debriefing the couple of main points that you saw. So when we talk about that debrief, we're not diagnosing anything. So as PTs, we're not saying you have a lordosis or you have an anterior pelvic tilt, you have this, you have that. We're just going to debrief with them and tell them what we saw, what imbalances or differences from one side to the other that we noted. And then we can use that as a basis to prescribe some homework and also put some specific mobility drills or activation drills into their program.